Good afternoon, everyone, and welcome to our webinar on monitoring and reporting for the Commonwealth Partnerships Antimicrobial Stewardship Scheme. You should be able to see our screen and hopefully hear me. You also should be on mute, so we won't be able to hear you. We'll be recording the session and be sending the slides along with the audio later today in case you have any problems with connectivity or in seeing the slides. Throughout the webinar, we'll pause for questions at the end of each session, so please input your queries through the typed questions box on the right of your screen during the presentations, and we'll try to answer them at the end of each session, and we'll have Q&A at the end as well. Just for those who don't know me, my name is Richard Scone-James. I'm the Senior Grants Manager here at THET. I'm joined by my colleague Susan, the THET Quality and Learning Manager, and Diane, Global AMR Lead at the Commonwealth Pharmacists Association. I know we said about 90 minutes for this session. Hopefully we might be able to be a bit quicker than that, but let's see how we go. The session's been designed to outline the monitoring and reporting requirements for the programme. As such, Susan will talk through the framework for reporting on the programme as a whole, which is the programme log frame. Each partnership will then feed into this log frame with their own individual project log frames, which they will report to THET on a quarterly basis. Again, Susan will outline how partnerships should use this document. Finally, Diane will speak through the tools and resources available to partnerships that feed into each of the indicators in the log frame. And at the end, I'll conclude with next steps. So we're going to be sending these forms to you later this afternoon for you to start developing your plans. So I think I'll hand over to Susan for, yes, the logical framework.
Hello, good afternoon, everybody. As Richard said, please do send through your questions. The purpose of the webinar is to support you with completing the forms. There will be another opportunity to talk with THET about how best to do this. But if you let us know what issues make sense or don't make sense now, we will hopefully be in a better position to support you with the process. I am taking as my benchmark to explain the logical framework people who have had limited, if any, experience of doing monitoring of international programs. So forgive me for those of you who are more experienced and have undertaken this type of project in the past. The main tool that we are using in CwPAMS is a logical framework, like the one that you can see on screen. These are the most common tool now used in global health project management. They're useful not just for reporting progress, but also for planning and for program management. Their main role should be for the health partners themselves to keep track of how the program is going and whether or not you are managing to keep pace with everything that you said you were. For THET and CPA's purposes, the log frame is also the main reporting mechanism to us that will give us the data that we need to see the progress of each of the 12 projects, but also it will be the main source that we use for data to report to our funder, the Department of Health. So as you can see for the example on screen, these are 16-cell matrices with 4x4 format. This is the most common format. It's been slightly adapted, as you will see in a minute, for the program that we have. But it is to try to understand the logic of each part of the process, starting with the biggest change that you are looking to see at the outcome level, then how you will know that you're going on the right path through the outputs, and then the activities that you need in order to achieve your outputs and outcomes. All of this you've already started thinking through in your approved proposals. The next column along, indicators, is looking to see, well, how will you know that you have achieved your output, activity or outcome? What markers are you going to be using to demonstrate that you have achieved this stage? Moving along to the next column, data source, this is where you will be gathering data from to be able to prove what you have achieved. And the final column tells us what your starting point is and what it is that you are aiming at the end of your project to have achieved. So log frames should ideally be developed and included at the very start of a program or a project, and should be done with all health partnerships. That means the two main partners, the UK and the LMIC partners, but also other partners that you're likely to be working with. For instance, quite a few partnerships are the organisation that will be implementing the programme is not the same as the LMIC partner. The reason for having all of those that are expected to be implementing the programme, developing this from the start, is it helps make sure that you're all on the same page, that you have a shared vision of what is happening, to avoid misinterpretations of the process of getting there, to include all different activities that need to be undertaken to reach the outcome. Different people might have different perceptions. And to ensure that it's realistic, that different stakeholders, different partners may have a better knowledge of what is or isn't achievable in the time frame. So if we move on now to the log frame of this program. So this log frame is based on the same principles as what we've just been talking about. This column is what it is that you're looking to achieve. This is saying how you will know if you've got there, the indicators. And this is your starting point and what you're hoping to achieve. So it's essentially exactly the same 4x4 matrix structure. But because it's started to be filled in, there are more columns and rows appearing. The log frame that you have here is the approved framework that the program is expected to be reporting on to our donor, the Department of Health. So the CwPAMS program essentially must deliver everything that we are seeing here. Therefore, each of the 12 projects, we will be looking to see data which will allow us to report to the funder against each of these areas. Very little of this will be new to you because the outcomes were, I think, all provided in the original call for proposals. And actually, if you look at it, an awful lot of the proposals which have been approved and which are now projects in this CwPAMS resonate with each of these outcomes. So starting with outcome 1, we will need to be demonstrating that each of the projects is able to improve practice related to antimicrobial surveillance and prescribing practice. By improved, we are not just looking to see that something has been done, we're looking to see that actually things have got better. So the indicators that have been included here of how we will be measuring improvements in AMS and prescribing practice, the reduction in the use of broad spectrum antibiotics, firstly, and secondly, the percentage of institutions with different structures which would be seen as the best standard of AMS. So what we have done here is to define how we will be interpreting the indicator which is used to measure the outcome. The next column along on both of these indicators, as you can see, is blank. The baseline for this program, we will only be able to articulate once we have that information from you, the 12 projects of this program. That will allow us to develop some statistics of where each of you at the start of your project is as you undertake your baseline. And it will enable us to demonstrate what was achieved at the end of the 14 months of implementation. The targets relate to the number that we are hoping or expecting to see. Please don't think that this is a blueprint to which you must adhere. This is the overarching program log frame. It is we're showing it to you as a guide of what it is overall that we are looking to achieve, and to potentially give you some ideas of how you might want to look at your own project. However, therefore your project should be able to fit within this, but you are not expected to necessarily deliver on every single thing that is within this framework. In each of the baseline target sections, we have a column or a row for source. Source here means source of data, of where are you going to find the information to be able to demonstrate whether or not you've achieved your outcome using the outcome indicator. So where would you need to go to answer the question that there has been a reduction in the use of antibiotics? For us, we would expect to see that in the narrative reports that you are sending to us. It will also be one of the major questions of the evaluation which will be undertaken at the end of this program. But another important source of information, which each of you is required to do as part of your work, is from the global PPS. The second outcome indicator is showing you that we would expect to be able to explore this during visits in country, of when we would be able to visit Zambia, Tanzania, Uganda or Ghana, and be able to explore in person what changes there have been. So demonstration will not just be through narrative reports or surveys, it will also be through face-to-face visits. And that would also be an opportunity for you to share with us maybe some of the context of achieving these various outcomes. Moving on to outcome 2, this outcome, which is looking at some of the strategies, guidelines and tools, is we are interpreting as very much part of the surveillance system itself, some of the hard products which will be the kind of structure of the surveillance system. And the way that these will be measured will be the percentage of institutions which have them in place, and the percentage of institutions which are adhering to the WHO categories. As I think people will remember, an important part of the call for proposals and a requirement in the applications was demonstrating how every project aligned and harmonized or built on national guidelines or guidance, as well as international standards. So in this project, we are taking the WHO aware antibiotic categories as our tool to establish what it is that we're looking for adherence on. And again, the way that we would expect to report on this is through your reports, through the evaluation, but again through the global PPS. The third outcome is a critical part of this program, but one which to date, most of the projects that we have seen have given limited information on. This is an area that CET will be needing to work with projects on, as it is a requirement of the grant from the Department of Health. And that is to be able to demonstrate tangibly and practically how the NHS staff are building their capacity as part of this grant. The main indicators that we will be using to demonstrate this is how the UK Health Institution is actively including the developed skills of its volunteers. What that means is that we would need to be able to demonstrate how your trust or hospital or pharmacy is, what systems it has in place to absorb and incorporate your knowledge and skills, and what mechanisms you have for sharing those. One of the major tools that we'll be using to identify this is through a volunteer survey. Those who have worked with CET before are very likely to have been invited to contribute to volunteer surveys in the past. I think one of the significant differences on other grants we have managed and this one is that this will be more of a requirement than a
nice to have.
A nice to have. Because it's very important for the Department of Health to be able to demonstrate this, which makes sense given that it is money that could have gone directly to the NHS. So the second important indicator we're using at this outcome level is the percentage of volunteers who are demonstrating improved competences. So how is it that you are actually, in what ways have you changed in order to implement AMS in an LMIC setting? And the pharmacy fellowships is something that we will be using on this.
Yeah, I think perhaps Diane can speak to that in her session later if we have time.
Great. And also through case studies. But we think that this is an opportunity for volunteers to be able to articulate some of the important changes that they think that they have experienced in their professional capacity as a result of the programme. So I think that's that section. We're now moving on to the outputs of the programme log frame. So these are what we have seen as the essential building blocks to achieve the specific outcomes. Each output relates to an outcome above. And once again, these are being shared with you to demonstrate what we have to report on, and they may be useful to you, but we are not necessarily expecting to see all of this in the log frames that you'll be working through with your partners, and which we will be looking to see how things are going in the project. And as you'll see, each of them is going to the stage before you would see the actual change, or that's the idea of each of the outputs. So in a sense, they're the preconditions of what has to happen in order for the next stage to happen. So health workforce needs to be strengthened. This is essentially the training element, which was an important element of almost everybody's proposal. Staff need to be trained in order to be able to start changing their practices. And the indicators that we'll be using to demonstrate this will be tools around training with training logs. I think that Diane and CPA have been doing some work related to this tool, but also a number of different health partnerships have used such tools to see pre and post training change in knowledge quite commonly. One something that we are keen to try to introduce or include here is pre and post training, but not necessarily just immediately after the training, but over time. So it might well be that immediately following a training event, you will see an incredible improvement in people's knowledge. But if you're able to test their knowledge 3 months down the line or 6 months down the line, you're more likely to get an accurate picture of whether or not people have actually really absorbed and understood the training that was provided. The second indicator is about demonstrating that change. This very much relates to the way that they practice and being able to demonstrate any changes in practice as a result of knowledge. This starts coming into some of the area that those that participated in the workshop will have learned on the behaviour change done by
Lucy and Joe from MISC.
And I think that they shared quite a few materials which are available over website or have been shared by us, and that there will be a couple of volunteers who are likely to be working specifically with some of the projects to particularly look at this area of demonstrating change, and how to be able to identify it. And this then is the actual behaviour itself of what are people doing differently as a result of being trained. So in a sense, it's the 3 different levels. And you will see that one of the methods that we are thinking of as important to demonstrate this is observation. That could be observation of health workforce in situ by the health partners themselves, or during monitoring visits through PHET. But it's also quite a useful method of trying to articulate the change process. So the second output, as you can see, relates very closely to the second outcome, and it is the actual development of all of the hard documents and policies and guidelines which are essential before the AMS system is in place. And each of the indicators relates to a different element of this. So revised documents, so for instance, some institutions may well already have some guidelines, but they're not necessarily in line with WHO or with national guidelines. So it's ensuring that they're in place, that they're not just set up and approved, but they're actually rolled out, which means that staff will have been made aware of them and be in a position to be able to use them, so that they've been provided training in them, that they're being held accountable to them by their line managers. And the third output indicator is that data that is collected that all of this starts resulting in better quality data being generated and collected. And the source of information, so the way of collecting this document, again, is very, very similar, but you will see once again global PPS coming up. So this is the global PPS is likely to be one of your most important sources of data for this whole project. The third output indicator is the one that almost every project, I think, will need to be looking at how it will demonstrate that the volunteers that it has recruited have improved their knowledge and understanding of AMS. So these are 2 of the indicators we will be using, so that they'll be able to name a number of the barriers that may affect a health institution in an LMIC from implementing an optimum AS system, and also the number of days of volunteers' time which has been put into this. Volunteers' time needs to be looked at both in terms of time spent in the LMIC institution, but also the time spent virtually. So from the UK base, either supporting through emails or WhatsApp, webinars, Skype, etc. So this is the overarching log frame that we will be looking to report against. The next slide, this is the monitoring form template that you will be asked to complete. So you will see down the side, each of these are the outcomes and the outputs that we've just talked through. We leave this column for a minute. There's the indicators, baseline and target. So it's the same format. The additional column is for you to be putting in, oops, sorry, your data of what it is that your project is looking to achieve. In all of the application forms, people were asked to put down 3 areas of change. Excuse me. And this would be your outcomes of how it is that your project is likely to lead to your intended goal around improving AMS, AMR, and infection prevention. They do not need to be the same wording. You don't necessarily need to be putting information in each of these, but we will need to see some demonstration towards the NHS. That is going to be a requirement, but the other 2, I think every project in one way or another was contributing to the other 2 outcomes, but in different ways. You're very welcome to use the same indicators that we have used, or use those for guidance, for discussion with your partners from the previous slide, the ones that we've used. You're also welcome to have more than one indicator for each outcome or output. So our recommendation is it's far better to use fewer indicators and try to measure them properly than use many indicators and then struggle to find the quality data or to find the time to collect that data. So putting the time in now at the planning stage and saying which are the real deal breaker indicators? What is it that if we don't see this means we are not really able to demonstrate improved practice, for instance? Whilst many of you, I think, are already started to do the debt baseline.
Yes.
So many of you will hopefully be able to start filling in your baseline data against your outcomes, and will, with your partners, have been able to develop targets. A lot of projects had already put in targets during the proposal stage, but these are very likely to change as you do your baseline and as you've have further conversations with your partners of what's realistic. And again, it's far better to be realistic and overachieve than unrealistic and underachieve. It's not only a confidence boost when we achieve what we set out to achieve or gone over that, but it is also means that as a program we'll have a more accurate picture of what is realistic with the resources that you had, which will guide any future projects and work. The next slide is where I started trying to use one proposal to demonstrate what this might look like. So I tried reading one of the proposals that had been submitted and had actually been accepted to see how easy it would be for you to transfer that data into a log frame format. And the answer was that it was, it could have been easier, but it certainly wasn't impossible. So The project that I had looked at in a bit more detail, these are the 3 outcomes that the project had written down as what it wants to have changed as a result of its work. To have reduced antimicrobial prescriptions by a specific percentage in the healthcare institution within which they were working, and that they were going to use the defined daily dose as the measure of accuracy. And secondly, the percentage increase in the proportion of prescribers and dispensers demonstrating knowledge. So both of these were the outcomes that a project was looking at, which completely harmonize with the outcome of the project in general, which is fantastic. The question then would be how you'd be looking to measure this, with what indicators. This wasn't something that you had been requested to do at the stage of proposal development. So it's something now to start talking through with your partners of where would you find this information about the defined daily dose in the healthcare institution. Will that healthcare institution already have a logbook, for instance, working ward by ward, where you would be able to see this information? If not, is that something that you would be expecting to be developing as part of outcome 2, strategies, guidelines and tools, so that each health institution is able to collect such data on a regular basis and beyond this project? When thinking through how you're going to measure it and what your data source would be, it's really important to keep in mind the capacity of the staff that you're working with. People are incredibly busy, as we all know, overstretched, and trained healthcare professionals. If we're looking for this work to be completed by the health workforce in the LMIC, what will that mean to their technical job as a doctor, pharmacist or nurse? What time will they have available? If they do this, what will they have to stop doing in order to do this? So any data collection, any indicator and data source needs to be very, very sensitive to the realities of working in these healthcare settings. So the next outcome from this particular proposal was the establishment of the entire surveillance system. What it might be more useful for this particular partner to do is to break down what they mean by a surveillance system to its component parts. A surveillance system will be made up of many different elements. The more specific you are in what it is that you're trying to achieve, the more easily you will be able to demonstrate whether or not you achieved it. The next part is the outputs of the program itself. So the first one related to the training, where the output was people are trained in AMS. And this particular proposal had started breaking down who they wanted to train and how many they thought was realistic to train. We would need to be accessing data as much as possible on the cadre of person in the health system. It would also be very important that we're able to demonstrate gender, which is a big interest of the Department of Health, but also of FET, to try to start working towards gender transformation, whereby we are actively supporting and encouraging women to take greater roles in leadership, and building their capacity and confidence around all areas of health systems. The indicators that this particular partnership had chosen are down here. Adherence to local antimicrobial guidelines. So the guidelines are very much related to this output. For this indicator to function, this output would need to have already happened. So again, something for you to consider as you're putting together the log frame, to see the relationship between each of your outputs, and maybe to use that to see how sequentially you want to be implementing your project. If you start off with a training plan, but the way you want to measure the quality of the training can't really happen until you have your tools in place, it might be wise to change the order. The second one, again, I think is quite self-explanatory, of the guidelines being in place. And the third one was not yet completed, but is something that would be important that we see something of in each of the proposals. I am sure that that is enough of me talking. Maybe we can move on.
Yeah, so thanks, Susan. Just before we move on to Diane, just pause briefly, just see if there's any immediate questions now. So let me just look at any questions coming through. So Mariam is asking, will we have access to the individual responses for our institution on the baseline survey of MS that Chloe and Diane sent round to assess outcome 3? Yeah, so that's, I assume, related to the pre and post questionnaires that we sent for the inception workshop in Birmingham, I think.
No, it's not related to that.
Oh, sorry, Diane, you want to come back on that one?
It's about the AMS checklist. So Miriam, the simple answer is yes. We are planning to create it in a way that you will get an automated email back, which includes all your responses.
Okay, great. Thanks, Diane. If there aren't any more questions for now, then I can hand over to Diane. Diane, would you like to have the slides on a particular slide, or are you happy to speak without?
That would be helpful, actually. If we could go back to the outcome slide, that would be helpful. Thank you.
Also log frame.
The log frame.
Yeah, sorry, the program log frame. Yeah, there you go. Okay, thanks, Diane.
Yes, that one. Yeah, go. Okay, thank you. Hi, everyone. So very quickly, I just wanted to share with you what data sourcing instruments will be available to support you in collating data that would help you provide information that is required for the monitoring and evaluation, which needs to go back to TEF. So you will already be aware of the global PPS. So there's a whole process with that, including the reports that you get back from the global PPS. That will help you. The way we've specifically asked the global PPS to check is that they will be able to break down the antibiotics that you assess through the global PPS into the broad spectrum. And for reduction in use of broad spectrum antibiotics, we're focusing on the watch antibiotics and the restricted antibiotics. So reduction in that. It does mean a consideration of fitting in the consideration of how many how many PPSs could you implement within the time. So perhaps at the beginning and at the very end, because then that helps to show that reduction in use. And when we were having discussions about this, we were highlighting that it doesn't have to be the UK team who carry out both PPSs, but actually from you training them as part of the initial and a part of the induction, will they be able to carry out the final PPS or the second PPS as a way to also show that increasing capacity and capability of the partners that you've been working with. So all that data will be available. The other tool that is available is the AMS checklist, which is what Miriam just alluded to. And we've been going through a Delphi methodology to consider which of those indicators are really key for each project. So what we did was to use the consensus document, which is an international consensus document, to highlight the key indicators from the consensus document. And we went out to partners from partners we had access to within the UK, but also our contacts in the countries through the pharmacy organizations that we've been working with, and asked for an assessment for each indicator of how relevant they are to your projects. And there was a score of 1 to 5, 5 being most relevant and 1 being least relevant. So we got that, and we had 6 partners within the UK teams who provided that information, looking at their project plans already. But we also had 6 responses from Ghana, Uganda, and also Zambia. And from Ghana, we went to, as I said, we went through the pharmacy organizations to seek individuals who can provide that, who have a good understanding of AMS within the country, either through their work in hospitals or through their work through research, or as a national organization. So we have 12 responses that we have analyzed, and so we are now going to, from that data, create the final AMS checklist, as we've called it, based on those consensus, based on the consensus process we've gone through. As many of you will know, through Delphi methodology, you usually sometimes will go through a 2-round process, but actually the data we've got is so similar that we don't even have a need to have a rescoring, and we're going with only indicators that have a 4 or 5. So that's basically saying very relevant or relevant as the indicators that we'll take forward. Any indicators that are 3 or below, we will be dropping. So hopefully that provides you the information around the data sources that you can use, which will help you with outcome 1.2, but also provide you with information around outcome 2.1 in a way as well, because you will be able to have a baseline of what guidelines and tools and protocols they have in place through that process. And the way we envision is that this AMS checklist can be completed over a telephone conversation with the teams, but just teasing out and working out as a partnership what the baseline level is. As part of when we were seeking the consensus for this as well, we asked for feedback around what behaviors are going to be part of your projects, or that you're trying to assess within your projects. So we had behaviors such as antibiotic guidelines should be easily accessible and relevant. Doctors should be confident, but that's by reducing their unnecessary prescribing, they can offset antibiotic resistance. There were 19 behaviors that 18 behaviors that we listed out using the knowledge we also gained from Lucy and Joe at the Inception workshop. And from that, we asked you to score which of them you were trying to achieve within the projects. And again, we've got those scored, and so we will basically be taking those that are the behaviors that are consistent throughout the partnerships. And what that means then is that we can help develop a tool. Susan mentioned around, also measuring behavior change. So we can help develop a tool that basically will help support you in assessing behavior as part of your training assessment. So you will notice that when we send you the pre and post training questionnaires, that gives you an example of the kind of pre and post training surveys that you could create. And what we will do is create a template that you can use, but we'll also create this survey that you can distribute or disseminate through your partnerships. And again, we will pull the data for each partnership and provide that back to you for your individual analysis. And it also means that we have an oversight for all partnerships as part of the program and our requirements to report back to Department of Health. So that's the AMS checklist, the behavior tool that we've got, and also the global PPS. So this is giving you we showed you these as part of the Inception workshop. So hopefully what I'm doing is giving you an update on where we are with them and how they fit into the log frame, and hopefully helps you understand why we started to develop them in the first place, and that you will find them useful to use as part of your block monitoring as well. The final one is the training template. And again, I mentioned that very quickly as part of the behaviors, is that we will basically provide you an example that you can adapt and use within your local settings as you wish to. I'm going to pause there now to see if there are any questions, and take those questions. And then I want to just very quickly talk about the networking platform as well, and also give you an update on the app. So if there are any questions, I don't know if any have come through whilst I've been talking.
There's one. Yes, there is one question. I don't know if you can see that, Diane, or should I read it out?
So there's one about from Louis says, I'm sure this is coming from a good place, but I'm increasingly concerned that this is becoming quite a top-down project, with projects becoming research assistants and more tools and instruments being pushed down on teams. Louise, the tools are there for you to use. You do not have to use them. They are being supported. We as part of our technical offer, and what Department of Health asked us to do, we said we will provide instruments and tools that are available. I'm not sure if you're talking about the monitoring side or if you're talking about the tools available, but the tools are not compulsory for use. They are meant to be supportive, and those who have been part of the consensus have found them very valuable to use. So Miriam says, I'm very grateful for them. I don't have time to develop them. That's fine. I don't know if Teth has got any comments on the monitoring side.
Andrea has a question. What did you mean by the training templates? Is this the pre and post questionnaires?
Yes. So what we started to do this, and yeah, it is basically, but I mean, in many cases, if you have a copy of what we sent to you as part of our assessing, so when we were trying to assess our training, because we have to also show this to Department of Health, we developed the pre and post training survey. So that's very similar to what I mean, is that you can literally take that and use that method to develop your own pre and post training survey. But with the template, what we were trying to do is to highlight how we mapped it to the WHO competencies, because if we're going to map around AMR and AMS training, we need to try and use the WHO competencies assessment document that is available. And so we show how we decided which of the competencies we would be meeting as part of the training, and then how we developed questions to match those. And then we had them as a pre and post. And obviously we will then be able to provide a report to say that as part of the training, these were the competencies. So that's what the template is there for. But obviously, because we don't know exactly what topic you're going to be training on, we can't develop an overarching training document. But the behaviors one will give you, again, things you can pull from to use.
Thanks, Dan. I think that's all the questions for now. Did you want to, if you go onto the app and the platform,
yes,
then I'll conclude.
Cool. Thank you. So the very quickly, just to say, with the app, we are now at the stage where we we are populating the app, and we are hoping to be able to launch the app in the middle of April. So we are very, very quickly putting all the information, and we're focusing around the WHO aware categories in the first instance. So that's going to go on there, but also the various national guidelines that we can find. Obviously, we can't provide the national guidelines in an app format, but we will provide a signpost to them through the app as well, and a range of the different resources that we have available. The networking platform as well is now live, and it is www.CwPAMS.co.uk. And on there, as we highlighted previously, there is a forum, and there is also an opportunity for you to have conversations about different topics, and we have populated it with all the resources that we collated as part of the scoping. The resources that people have highlighted that they wish to have all now been added to the networking platform. So most of the people that attended the Inception workshop have a login, and you had a login to the stage site. Your login and your password are exactly the same for the live website. So please do go there to visit and have a look and start conversations. And that's all I was going to say on those, Richard.
Great, thanks, Dan. And so following this meeting, I'll put an email together and just send it to everyone, and I'll include the link to that platform in there. So in terms of next steps, do please ensure that all relevant colleagues within your partnership watches this webinar. It's hopefully a useful base from which to start populating your monitoring forms. I will include the monitoring form and the log frame, the program log frame, sorry, into the email list this afternoon, so you have that as Word documents. And so, yeah, so what we'd like you to do with that monitoring form is determine which of the outcome and output statements and indicators are relevant for your project, how you will measure these in line with the whole program log frame, and what targets you will set for each indicator. I just want to press home again the point that we are very aware that targets will change from those that you put in your original application form. We expect them to change, whether that's up or down. If it varies significantly, of course, we'll have a chat about that, but don't feel completely beholden to what you put in the application form. And we request that you email the first draft of this form to your SET grants manager, no later than Monday the 8th of April, so that's 2 weeks from now. If you can do it any quicker, then obviously that would be very welcome. But if we give you a space of 2 weeks to develop the first draft, and then we'll have an iterative process over the next couple of weeks after that to try and finalise that form. Then, as you should all know, the first report is due on Wednesday the 15th of May. So the idea is that the monitoring form that you're populating will be complete by the start of May, and then 2 weeks later you'll send us your first report on that form. Obviously, we won't expect very many indicators to have been well, none of the indicators will be fulfilled, but any progress towards them would be great, but not expected. And I think that's everything. We will just, that's right. We'll disseminate the report template, the narrative report template in mid-April. It'll effectively be a version of the monitoring form that we've shared with you today, plus a few extra narrative boxes, which you can fill out. For those of you who have done SET reports before, it's not nearly on the same scale as those in the Health Partnership Scheme. or the Africa Grants Programme. This first quarter, it will be a very short report. So yes, thank you. That's everything I have to say. If there's any more questions, briefly I can take them. Otherwise, we can obviously follow up with any questions afterwards. So I'll just pause now.
Can I
Yes.
say something, Richard? Just I mean, something else to flag to partnerships is that there is a monitoring side, and it may seem like there's a lot of data collection as well from one of the questions, but a reminder that this project is very unique, and it is a pilot project, and in many ways, DH are looking to be able to go back and seek more funding for this to be expanded across the whole of, to be expanded. And so our monitoring and evaluation is quite key, and actually that's normal anyways for any TEF projects, but it's also important for those purposes as well. And I'm sure Susan will be able to say more around monitoring and funding and things like that, but this is it's different to other projects that have been funded, and it's funded specifically around trying to tackle AMR through stewardship, again, which is new. Infection prevention and control is quite embedded already, but this is the first time the stewardship is being funded in this way.
Yeah, thanks, Dan. So yeah, we've had a question. Obviously, the 8th is the same date as the Uganda and Zambia and Tanzania workshop. So if you were planning to have meetings with your partners afterwards, after they've attended that event, obviously that's totally understandable. So I just ask if you feel that date is a few days too early, just get in touch with your grants manager. So it'll be B for those grants, and just yeah, agree on the date later in that week. Okay, I think that's all the questions we have. So yeah, I think we can wrap up. Obviously, do send me an email with any further questions you have as you go, or your grants manager. If it relates to the tools that Diane was talking through, then please do email her or CPA team members directly. And yes, thank you very much. I'll get in touch with an email later this afternoon.